So hello everyone. Thanks a lot for joining in. Good morning, good afternoon, good evening, based on whatever part of the world you are joining in from. So today's discussion is a very special one for me. Then this is something I'll come to later. But firstly, thanks a lot for making time for today's call. So I'm Rohit Ghosh. I'm one of the founding members of Cure.ai and currently acting as the Chief Strategy Officer at Cure. So over the last 3 years, right, we have seen almost approximately close to 58 million casualties because of the COVID. But in 2020 alone, another pandemic infected almost close to 102 million people. Remember, the number for COVID-19 was 58 million, right? So this pandemic has resulted in almost 1.5 million deaths. It is not only the most deadliest infectious disease in the world, but it's also seemingly the most silent one. I'm referring to tuberculosis. That's correct. So in the meantime, one more statistics just for, put things into context. Lung cancer is another one of those lung diseases that has taken almost 1.83 million lives in 2020 alone. And with almost 40% of those cases being diagnosed in later stages, leading to slightly inferior outcomes. So with just one more week to go for World Tuberculosis Day, I felt the need to make this above points because it's good time to remind all of us that what we are trying to do in terms of making towards a goal for TB eradication in India, right? And that's where this panel is coming together to sort of discuss a bit more in terms of what can be done in not only TB, but what we are calling as universal lung health, right? Now, let's take a pause here, right? Then this is the part where I'm sort of most passionate about, right? What is universal lung health, right? And this is a concept I think we have heard over the last 3-4 years, and there's a lot of doubts and questions, right? And I just explained this a couple of weeks back, I think, on social media. Let me give you a very small example. If you buy a TV, are you just going to use it for only watching one channel or one sort of OTT thing? No, right? If you're going to buy a pack for internet, are you just going to browse only one website? No, right? So if that's the case, then if you're developing a complete infrastructure to tackle one disease, why are you just going to limit it to only one single lung health disease and not just cover everything that is happening around the place, right? Starting from COVID-19 to lung cancer to a bunch of other lung health diseases, right? So there's a entire infrastructure that we have built for tuberculosis. Can we take it beyond? Personally, I strongly feel that answer is a passionate yes. But today it's not about me. Today's discussion is primarily from the esteemed panelists who have joined us, and to get a understanding from them in terms of what they think in terms of, can we build something like that? Is there a possibility to even think about universal lung health? So without further ado, I'll just get started. I'll do a quick round of introductions so that you all know, who have joined in and the great wealth of experience all of our panelists would be sharing with us. Starting with Padma Shri Professor Dr. Digambar Behera, who is the Director of Pulmonary Medicine at Fortis Hospital in Mohali. Dr. Digambar was conferred the Padma Shri by President Ramnath Kovind for his commendable contribution to the field of medicine. He has over 40 years of clinical experience. And honestly, if among the entire panel, if someone is a truly living example of universal lung health, right? It's him, because his Padma Shri was primarily for the pioneering work that he did in chemotherapy in lung cancer. As well as in his previous role, he has been the head of Department for Pulmonary Medicine at PGI and director of the National Institute of TB and Respiratory Diseases for 5 years. Thanks a lot, Professor Behera, for joining us. Had it been a proper physical conference, we would have a round of applause, but I genuinely request if we could have a virtual applause for Padma Shri Professor Dr. Digambar Behera. Moving on to our next panelist is Himanshu Sikka, who's the Project Director for Samrit and the Chief Strategy and Diversification Officer for Health at IP Global. Established by USAID, Samrit is an initiative that uses blended healthcare financing to create an inclusive healthcare system for India. Himanshu has worked with several agencies like WHO, USAID, and World Bank in diverse geographic settings across India, Bangladesh, Philippines, Myanmar, Ethiopia, Kenya, and UK. USAID very recently, in partnership with IPE Global, has awarded Cure as a generous Samrid grant to support the scaling up of dual screening of tuberculosis and COVID-19 in close to almost 50 sites across 15 plus Indian states. Uh, Genuinely thankful to you again, Himanshu, for joining today, and hope to get your wealth of experience across not only India, but other geographies that you have worked in terms of how we can make universal lung health a reality in India. Moving on to the next panelist is Madhav. Madhav Joshi is the CEO of India Health Fund, which is a joint initiative by Global Fund and the Tata Trust, and has played a crucial role in scaling up of the use of advanced technologies for tuberculosis screening in India. In fact, one of the most common legacy that I was telling Madhav that we have right now is the TB Quest Awards. I think that has been something that has been in place for last so many years, and has actually, Cure was one of the recipients of TB Quest Awards back in 2019. And there have been some wonderful innovations that have been supported by IHF in the last few years. So thanks a lot, Madhav, again for joining in today's conversation. Hope to understand from you how more and more innovation towards a universal lung health could possibly take shape in India. Next up is Naresh. Naresh Asija is the Vice President for Viatris Pharmaceuticals, and Viatris is possibly playing the most crucial role in the entire ecosystem in terms of, once you have to sort of, the infrastructure of where you detect patients, the medicine that is delivered, the drug that is delivered to them. Viatris is one of the key players for tuberculosis, and they have also been working with Cure to improve tuberculosis screening in India. So thanks a lot, Naresh, also for joining in, and hope to hear a lot from you in terms of what pharma thinks and wants to play a role in terms of universal lung health. And most importantly, I think I have got, on behalf of Dr. Mangala Gomare, Dr. Pranita Tipre, who's the CTTB officer from Mumbai district and part of the Municipal Corporation of Greater Mumbai. MCGM has done some pioneering work and has partnered with Cure to improve incidental TB detection in the city via surveillance model to detect increase in TB notification. So I would like to take a minute to sort of explain what is very different from the work that we have done in all other places versus the work that we have done at MCGM, and Dr. Tipre has been leading that inside out. In most of the places, what we do is an active case surveillance, active case finding program where you sort of go out and find more TB cases. This is for the first time, I think, I don't know of many other places where we implemented a passive surveillance program, which means that you could have patients do all kinds of x-rays for different reasons and actually pick up incidental TB patients from those patients. So this is something that is very interesting and very different, and actually one of the core ideas possibly behind universal lung health, that if you can detect more number of disease from incidental detection, then possibly that's a starting point to actually getting that infrastructure together. So that's a bit about all of our panelists. So we'll have a few questions lined up for our panelists, possibly going on to around close to 40 minutes, 45 minutes. After that, we'll open up for the Q&A. Meanwhile, if you have any questions that you think is, it's bothering you, want to sort of get an answer to from one of our panelists, please feel free to type into the chat box. We'll try and take that up towards the end of the session. So that's about it. Thanks again for everyone joining in. Let's get started. So first, I think I'll just quickly want to get an idea from all of our panelists in terms of the work that they're doing. If you could give a small introduction about yourself and the work that you're doing specifically in lung health, right? Whether it's universal lung health or TB or COVID-19, maybe that would be a good starting point for all our audience to understand your perspectives better. So maybe if I could go around the room, starting with Professor Dr. Digambar Behra, Himanshu, Madhav, Naresh, and Dr. Tipre. Dr. Behra, I think you're on mute. So maybe if you could just unmute yourself.
Yeah, thank you, and a very good afternoon to all of you, and to all the listeners. You see, myself, as you have already introduced, I am basically a pulmonary physician. So apart from my patient care, I was a teacher also, and I do a little bit of research also. When you talk about lung health, obviously the various lung diseases and the understanding of pulmonary medicine in this country has undergone a great change. Our earlier trainings were basically focused on pulmonary tuberculosis and tuberculosis. Yes, that was rightly so. So obviously the scope of pulmonary medicine has increased over the years. It is not only tuberculosis or other communicable type of lung diseases. It is the non-communicable lung diseases that has also taken a great toll. If I say various chronic lung diseases like COPD, asthma, I don't think that may be a focus today, but I'm just give a brief idea about that. Those diseases are increasing over the years. Say, for example, as per estimates, in 1990, if we have got around 26 million cases of COPD, now in 2018, it is nearly 55 million. It is almost, double. Similarly, asthma, we have got the asthma in this country will be nearly 3.8 crores of people have got bronchial asthma. And asthma is a disease, as you know, it comes and goes, comes and goes. So one person itself is many times a case of asthma, if we think that way. Similarly, other diseases like interstitial lung disease, that is also increasing. We are seeing a large number of interstitial lung diseases. We have got issues of bronchiectasis, occupational lung diseases, and particularly some of the factors which are associated with various lung diseases like smoking, pollution. So they are coming on in a very great way also. The smoking, although it has reduced a little bit, but still about 28% of our population is smoking. And similarly, the pollution issue, I think every time, every day you hear from the television, you read from the newspapers. And the tuberculosis, you have already told, you have got still a case of 27% of the world burden, the number which you had quoted, is in India. It is expected that between 28 to 30 lakhs of new cases of TB still occur every year. You have told about the mortality, the issue of drug resistant TB, the management maybe with the subsequently we'll discuss about that with more focus on TB. So as I told you, as a pulmonary physician, I am obviously handle and treat all these patients, but that is more in a hospital setting. And as a teacher, as I told you, as I teach also about pulmonary medicine. And just one line about the research. Actually, right now, I'm speaking from ICMR headquarters in New Delhi, where I was chairing and the meeting is still going on. I came out to take part in this discussion. We are just undertaking the world's largest vaccine trial for tuberculosis. So 18 different sites are taking part, and that is what we are discussing. Their presentation is going on. So that is what, and some about research and my association with the Indian TB Research Consortium, which is created by ICMR. I am also somehow associated with this. And the 3 divisions, I am chairing that, the therapeutics, this is the vaccine trial, and then the epidemiological division. So that is what is my work, and that is my brief comment about the issue of pulmonary disease. I just try to give you a brief perspective of lung health in India. Thank you.
Thank you, Dr. Behra, for that very brilliant work that you're doing. I mean, honestly, what you said about the vaccine trials going on for TB, right? That's something we have been hearing for long, and I'm so glad to hear that that's actually happening, right? That's a very strong example of something that was successful for some other lung disease, and that we are trying to now replicate for TB. So great to hear that. And Would love to come back to you in terms of understanding a bit more about some of those projects. But before that, over to you, Himanshu. If you could give us
Thanks.
a
Yeah,
brief idea of how IP and USN
sure.
is looking at universal
Thanks.
lung health.
Thanks a lot. Thanks a lot, Rohit, and thanks, Dr. Behra, about the work that you are doing. Uh, in terms of IP Global and specifically with USAID support, we have been working in the areas of lung health through the PEHEL program and other initiatives as well. Through the PEHEL program specifically, the Samrit Healthcare Blended Finance Facility was formed at the onslaught of COVID-19 to address the challenges that COVID-19 would be throwing at us. And what we are trying to do through this facility is that using philanthropic capital and commercial capital, merging the two for the benefit of the healthcare innovators like Qure.ai and many others who are either working in the diagnostic space, production space, primary healthcare, secondary, tertiary healthcare, and who want to expand their operations but are facing challenges because of lack of affordable capital being available to them. So that's what Samrid is trying to do. We are now a $250 million facility, having supported around 22 innovations, including Qure.ai, and growing strong day by day, overall reaching to roughly around 18 million people over the last year and so. So that has been one of the main initiatives where besides Qure.ai, we have supported some other diagnostics and curative initiatives focused on lung health. The other initiatives under the PEHEL program itself has been the Mukti Pay for Performance instrument, which is the world's first pay for performance impact bond being done in Madhya Pradesh, focused on nutrition and tuberculosis. So it's a well-known fact that weight gain during TB cure or TB treatment is one of the key things that one needs to look at, and where majority of the patients lag behind. The average weight gain is typically 2.5 to 3 kgs, where it should be 6 kg to 7 kg. So through this pay for performance instrument, we have been able to successfully demonstrate that how weight gain can be done through kind of focused provision of food baskets, protein-rich food baskets, as well as community level behavior change communication. This is being implemented in partnership with Child Fund, and now government of Madhya Pradesh is also planning to scale it up using its own resources under the brand name Nikshay Patra. So hopefully it will get scaled up in MP this year and continued in other states. Under PEHEL itself, last year, we also worked along with the union on the corporate TB pledge and brought together 100 plus corporates across the country, as well as some international corporate partners working in India, to work on different aspects of TB care within their organizations, around their geographies where they operate, and larger programs. So we brought in together 100 corporates, and that platform is still active and growing as we talk. Besides that, like Dr. Behra mentioned, there are other aspects of lung care as well, asthma, COPD, etc. But one more thing is around pneumonia. And pneumonia also happens to be one of the largest mortality factors when it comes to especially child mortality in India as well as globally. Globally, pneumonia causes around 2 to 4 million deaths, which is a big number, as you were mentioning about the deaths caused by TB and COVID. So within the pneumonia space, we have been working with several manufacturers to see how pneumonia management and diagnosis can be taken up at the primary healthcare point itself. So specifically, we have worked with a partner which has a multimodal pulse oximeter, also uses AI to some extent, and can be used for diagnosis of pneumonia in children in say less than a minute's time. So those kind of, that's another initiative in pneumonia management that we've been working on. So that's just a summary of different initiatives across the spectrum of lung health that IP Global has been working on.
Thank you. Thanks a lot, Himanshu, for that. I mean, that's amazing, right? I mean, you talk about nutrition to, sort of work that you're doing on pneumonia and now obviously PEHEL and Samrid itself, right? I mean, we did not talk about that. So Samrid itself is sort of TB and COVID-19, right? The work that we are doing with IP. So yeah, genuinely, I mean, it's very amazing, right? The kind of complete, very, very different sort of things that you're doing, and you have already seen success, right? I mean, the work that you did with MP and scaling up. So congratulations on that. We'll come back to in terms of understanding some of the challenges maybe, but before that, off to Madhav and trying to understand from Madhav in terms of how IHF has been seeing at universal lung health, right? And what kind of innovations do you think are the ones that possibly are going to create an impact there?
Thank you. Thank you very much. So I lead India Health Fund as the CEO. And India Health Fund was set up as a partnership between Tata Trust and the Global Fund, representing the world's largest investor in infectious diseases and the nation's largest non-government player in public health. But when they came together, it was on the thesis that communicable diseases had over time suffered from market failure. And the market failure was particularly in the availability of capital that was needed to take promising technology from lab to market. So India Health Fund was set up to really address that gap, which is to de-risk the development of promising science and technology, to enable its development, clinical validation, and pilot, to make sure that it was ready for adoption in both the public and the private health systems. And in enabling this de-risking, really create public goods, which could improve outcomes in the diagnosis, treatment, and prevention of not just communicable diseases, but also address other public health issues. So what we do is not only identify promising technologies through a number of means, but then also support them by way of funding, technical support, as well as linkage, market access to both the public and the private health systems, to make sure that we not only enable development, but also pilot, evidence generation, adoption, and scale. And in doing that, we also then work with a number of other players to facilitate the capital that is needed not just to develop these solutions, but also sustain them, because these are eventually need to survive in the long term. I think it's quite a privilege to have this panel, because we've worked with a number of the partners represented in this panel. Dr. Tipre and the team at the Municipal Corporation of Bombay partnered with India Health Fund to implement the nation's first bidirectional screening program for TB and COVID last year, when the concept had just started, very much aligned with the theme of today's discussion, which is universal lung health. Obviously, Qure.ai has been a close partner of India Health Fund and one of the early recipients of our support to not just develop, but I think a number of partnerships that we have now set up to enable the adoption of the Qure solution, not just for screening of TB, but also for COVID and now increasingly for COPD, with a number of players in both India and other parts of the world. And with the PEHEL team, with whom we've had a number of engagements, again, to facilitate not just piloting, but also funding and adoption. So I think what we do is not just facilitate development, but also facilitate collaborations and partnerships among like-minded players to really develop and scale promising technologies. Over.
Thanks, Madhav. Thanks a lot. I mean, honestly, I think of everyone in the panel, I think IHF and the role that you are playing is the most critical. Right? You're sort of the one sort of glue that's sticking together the entire ecosystem, taking the innovation, taking it to, to the point where Qure was, right? I'm sort of taking it to the point where someone like Samred and Himanshu could come in and sort of scale that up, or Naresh and the team from Beatrice could do that. So, yeah, you have been the one who's been working with everyone and sort of making this entire ecosystem get there. Thanks a lot, Madhav, for that. Now I'll just quickly come back to Naresh. And Naresh, I think what we have been discussing so far, I think what Madhav was mentioning in terms of the diagnosis and the treatment and all the innovation that happens. Treatment is also one of the innovations that IHF has been supporting. But obviously, as pharma, you have a lot more interest and maybe possibly also vested interest in terms of getting more number of universal lung health in practice. So just want to understand your thoughts in terms of how you see universal lung health play out, and also what do you think is the pharma's role in that particular space?
Thank you, Rohit. And first of all, before we speak about pharma interest, so I find this panel very, very interesting. Actually, we have heard a researcher how he has been working around, and then we have heard Himanshu talking about how they take execution, and post that I think Madhav has clearly evolved how he has evolved Qure. And now I think it is our time where we do go to market for these kind of innovative solutions. So as I started earlier, I have 20 years of experience in healthcare, both private and public side. So my major focus across my career has been like bringing a lot of innovative ideas and making it happen. So this is what I think very strongly, and we work very closely with our global folks. And we were I will say that pill company, and we were making medicines. We thought, why don't we become a healthcare company? So to do that, I think we evaluated a lot of solutions. We did hackathons. We evaluated a lot of solutions which can become go-to-market for us. And I see this platform very, very interesting, where both Himanshu and Madhav can play a big role, helping us out to give us proven solutions which we can do go-to-market. And coming to Viatris, basically Viatris is a US-based company, and our major focus is infectious disease, where we have started our major business in formulation with HIV infection, hepatitis, viral hepatitis, COVID, and of course, privileged to work in lung health. Now, I think tuberculosis, where we are going to provide one drug access for MDR, we have already provided, and the second drug is under, after approval, it is under guidelines, it's going under guidelines. So I think it's very interesting when you work on a disease and when you try to do full disease management. So that is the area where I see now a lot of innovation is happening in that space. We are very, very keen to learn that space and do good go-to-market. Thanks, Rohit.
Thanks a lot, Naresh, for that. I mean, I don't know. I'm hearing myself twice over, but I don't know if that's true with everyone. Maybe this is. So yeah, thanks, Naresh, for that. I think Viatris has been playing a very interesting role. Right? I mean, starting from hepatitis to now lung health, and there's like that entire thing that you are looking at. And as you said, it's a very interesting piece where you're sort of taking on from stuff that Madhav or Himanshu are sort of pioneering, and then sort of figuring out how to scale that. That's a very interesting place to be in. But one thing now I want to understand is that amongst everyone here, I think someone who's actually on the front line and actually dealing with patients on a day-on-day basis, and possibly the one who's has a much more profound impact on actually making universal lung health, if at all a reality, is Dr. Tipre. And I would like to hear, Dr. Tipre, from you, your perspective on not only universal lung health, but also the idea, right? When we did that whole project, and which is still ongoing in terms of passive surveillance, right? In terms of incidental TB detection, not just active case finding. How did you even come up with some interesting idea like that, right? I mean, what were the genesis of that, and how do you see that possibly playing out for other incidental lung health diseases?
Thank you for asking this question. Basically, being a pediatrician, but working in public health, you know that Mumbai has a 3-care delivery system, as we have been taught in medicine, primary care, secondary care, and tertiary. So being at the primary health care and now looking after TB program, chest X-ray is obviously the first screening test that we look at when the patient comes with the symptoms. So what we have done before, before actually I met the Qure.ai solution. So in Mumbai, what we had done, we had outsourced it through the NGOs in the private sector. So getting X-ray done and report in the government system at times take 2 days, the report coming. So in the private sector, when we give the vouchers, patient doesn't have to pay, the program is paying the bill. So we get the report, not only get the report, but the X-ray for the clinicians to see and opine and diagnose the cases. And the day I met and I saw the system, I think World Conference, which was there in Hyderabad, I saw this solution. And
that's correct, yeah.
Yes. And then the option came to apply for the funding. Lucky MCGM that we got the funding and we started this project. Looking at the TB burden in the city of Mumbai, like every year, 60,000 TB cases getting diagnosed, and almost 60% being the pulmonary cases, X-ray plays a very, very important role. And right now we have done a study and where we have found out that somewhere the TB infection rate in Mumbai also is around 50% in the household contacts. And that is the reason why Mumbai is seeing so much or so big a burden of TB. So if at all we have to like cut down the TB cases in the city of Mumbai, we have to see each and every option available to us, look at it as an opportunity and encash it. That's where we applied, we got the partnership, and incidental diagnosis started. Thank you.
That's actually very interesting. I mean, the word that you used, right? I mean, to encash every opportunity. I think that I think I've heard this term just recently, few days ago on social media. It's called opportunistic screening, right? So every opportunity that a patient is at a hospital facility, how can we sort of take that advantage of that and sort of do a little more than what is sort of asked, right? So that's a very interesting idea. I mean, how you mentioned that and how you describe that. Question, Dr. Tepre, back to you is trying to understand now that, I mean, of everyone here, you're sort of doing this on ground every day. You have seen the project sort of pan out. I mean, by the way, to everyone in the audience, this was something that was supported by Stop TB. So that's a fund Dr. Tepre was mentioning. So Stop TB obviously came in and we did this project. But what do you think is a major challenge when you sort of try and do this, right? I mean, once you, let's say, detect incidental, because these are patients who are coming in with absolutely no idea, right, that there's a possible TB in that. How do you, firstly, from, how do you break that news to patients, right? Because these are patients who have absolutely no idea that there would be a possible TB to them. How do you break that news? And once that happens, is the care delivery system in place to sort of take care of them? What do you think are the major challenges when you sort of try and do this kind of an incidental detection?
So it is, we have tried to establish some SOPs, when we were implementing this program. So technology has helped us a lot, the NTP staff working closely in these setups where the solution has been implemented, they get a notification that this person may be a suspect through the Qure.ai, that infrastructure and the technology that we have. And this staff then calls them up and talk to them and counsel them a little bit that you may have TB. So why don't you get your sputum tested? So that is how we reach out to them. So either it is the staff who does it, or we go back to the clinician and we ask the clinician to do the favor for us.
Understood. Understood. Thanks a lot, Dr. Tepre, for sharing that on-ground experience. I just saw a note from Dr. Behra that he has to sort of leave in some time. So before you leave, Dr. Behra, I just really want to get some idea from you in terms of where you have seen everything from lung cancer, sort of pioneering that entire chemotherapy, to sort of the entire work that you did in respiratory disease and TB, to the work that you're now doing with the vaccine trials. There's so much of things that you're, sort of overseeing. I just wanted to see, do you think there's an infrastructure that is already existing that we can leverage in terms of universal lung health, right? I mean, you have seen it for all diseases, right? Do you think it can be unified in some ways, or do you think that the infrastructure is possibly not even mature enough to sort of do that kind of unification? Dr. Behra, if you're on mute, you would need to unmute yourself.
Yeah, sir. The problem about lung health is somehow, by and large, obviously our healthcare delivery system is, the country is a little peculiar. In India it is diverse. So we have got predominantly a government or the public sector, and we have got private sector, which is equally important and contributory. And of course, there are other systems of medicine. I'm not going into that. I'm strictly speaking about the so-called scientific way of delivering healthcare, if I put it that way. You see, what happens, our medical infrastructure for example, for TB, we have given highest priority, and obviously our infrastructure is in a way is in place, or whatever, we have got a definite strategy. But I think even that needs little reorientation. Let me put it very clearly. I'm working on the field of TB for over a very, very long time as the director of National Institute of TB, then getting involved with the program as the chairman of task force in the country, and now its advisor. And then in the Indian TB Research Consortium, as I said, very rightly you talked about the TB detection. So all these aspects of implement the therapeutics, the implementation research. So all these things, as I have seen, what I think we need little reorientation. We have got possibly many things in place, but that needs we have to put it in its perspective. Let me example, as Madam told very nicely, that is about Bombay. They have told, yes, that is a good strategy. And then the program has got a strategy for detecting early detection of cases through earlier our strategy was, it was passive case detection. I'm just giving one example. So then the strategy shifted to, the targeted population, the specifically high risk population, the slums, the household contacts, diabetics, like this. So that is what is actually focused on. But I suppose still we are missing a large number of cases. Earlier you were telling 2-3 years back the missing million. Maybe we are trying to bridge that gap, but this COVID came in. So then we are again fixed. We lost detecting and registering or notifying cases. You know that during the time of COVID, last year I think we made up, we have reached about 21 lakh we could notify last year. The exact figure will come up this 24th of March. But in my information, it is like that. But still, that means another a few lakhs we are missing out. So I think there we have to change our strategy, like using technology, where I suppose the artificial intelligence, which is again coming up. And then interestingly, you'll be surprised to note that this our ITRC, or Indian TB Research Consortium, we are again trying to test that in a very huge way. It is already that is in a research mode, the artificial use of artificial intelligence in the case detection, that is being validated. Let me put it that way. I should not say it is validation, but it is in a research mode. But I think that is a great way. While we have evaluated, we have seen, and we are just waiting for the results. How did it work? How it is going to happen? But only thing is, the other issue, as I could see, anything we are experimenting, the point is we are just experimenting. That's all. Say, for example, let me tell you Madam's example. It is done only, they have taken up at Bombay. But what about the other parts of the country? It should be universal in a way. So I know it is very difficult. It needs expertise, it needs experience, it needs. But question is, anything good that has to be applied, because India, it has to be applied homogeneously throughout the country. I think that should be another way, whatever may be the innovation. But for the other sectors, unfortunately, there is no structured program. Let me tell you that way. For COPD asthma, it is part of the NCD program. There is a NCD program, but in the NCD, those 5-6 diseases are there. And the COPD asthma and the lung cancer as part of the cancer prevention program, it is there. But I don't think that is as active as it is for the TB program, because their emphasis is given there. So I am sure we are not formally in a very active form which is available. But I think I'm sure in one day or other, the government should come up with those things. And secondly, there needs a coordination between the private and the government sector. It is nothing, there is no, that should not be any compartmentalization. It should be private, this is happening, government, this is happening, and even for TB, a large number of cases are detected in the private sector also. So when you are using any technology, say for example, artificial intelligence, when you are using that, so that should uniformly be applicable, available, accessible to both sectors throughout the country for everybody. Thank you.
Thanks a lot, Dr. Behra, for that very interesting. Before I let you go, and I have a lot of questions actually for the rest of the panelists, but just one question. Since you mentioned about the NCD programs not being as active. When COVID happened, obviously we saw COVID-19 task force being formed, but then later on that sort of got merged with the TB department. And that's how sort of now I think TB and COVID-19 has sort of been looked at together, right? Do you think there's a possibility that obviously you as one of the pioneering visionary leaders in healthcare, in lung healthcare in India, is there a way we can sort of move the government towards sort of merging some of the NCD lung health teams along with the TB, and because TB and COVID-19, as you said, is possibly the most active things, right? Is there a way we can make that suggestion to a government in India or the CTD and TP?
Yes, I think we must do that. That is a very good idea. But the question is, and this is also the right time, I should say. It is also, it needs a lot of political and administrative will, and this is the right time when the government has got a lot of vision and they're trying to improve the health, and then they have got many other newer things they have brought in for the healthcare sector. I think this should be the right time. We should somehow bring this thing to the notice of the government also, that okay, apart from TB, which is the highest priority, as you know that the Honorable Prime Minister has shifted our strategy, NTB strategy from 2030 or 35 to 25. I do not know whether it is going to be possible or not. Maybe we have to shift it maybe another 1-2 years. Because of this COVID, everything went, haywire, let me put it that way. But still we could come out of it, but it needs some time. So, but you are very right, and I will fully agree and endorse with you. We should push it to the government and give this idea that, they should brought out a consolidated, comprehensive long health package, long health care package, and then use of newer technologies. I will be for that. Maybe existing technologies are possibly not enough, or possibly we are not able to utilize it fully. Maybe some other innovative ways need to be brought in. Thank you.
Thank you, Dr. Bera. Okay, I'll just come to Madhav. Now, I think Madhav, obviously IHF has been doing the TB Quest Awards. I think my first question to you is, when do we sort of see something like that for lung cancer, let's say, lung cancer Quest Awards? Or, I mean, obviously Global Fund came in and that's there, but there's also obviously the Tata Trust angle, right? I mean, it's just not about infectious diseases. So when do you think we are going to come up with a lung cancer Quest Awards?
Great question. So given, I think, the scale of the unsolved problems in communicable diseases, we're not going to stray from our mission of focusing on technology for communicable diseases. However, what we have started doing, and this is, I think, a strategic focus now, is to move from being disease-focused to identifying promising technology-led platforms, science or technology-led platforms, which can be adapted across multiple diseases. So again, I think QXR is a great example, which was originally designed for tuberculosis, very quickly adapted for COVID, has since evolved to lung cancer. And now, as you know, we are actively exploring the possibility of adapting it further for COPD. So as a platform, it's evolving, but the underlying technology remains the same. And that's our role, to really identifying promising technologies, which can then be adapted. We have just announced support for a very promising biomarker test, which can be used to do a predictive analysis assessment of drug resistance among patients for TB. 2 weeks from the start of treatment, unlike 6 months, which is typically what happens right now. But the same panel, the same biomarker test can also be used for COPD and has potential applications for cancer, a predictive analysis for lung cancer as well, because the underlying technology is adaptable. So I know that's not the answer that you were looking for in terms of a specific solution for lung cancer, but what we are doing is really being very choiceful in the science and technologies that we are actually supporting, because they're all adaptable. And that's really our focus.
No, that's actually a very interesting way to look at it. I mean, you start off with TB, there's a major problem, but you sort of try and focus more towards adaptive platforms that can be then sort of taken to other disease areas. I think that's a bit, if you're doing at IHF, I think honestly, that's, I think, a very big bit to contribute to the universal lung health story, right? I mean, that's possibly, I think, a very interesting contribution coming from there. Quickly jumping back to, I think, Himanshu, I think tell me in terms of when do you, I mean, I could possibly ask you the same question in terms of when do you sort of see a Samrid equivalent for lung cancer? But I'll possibly try and understand also from you, because of your international experience of having seen healthcare system outside and worked in even multilaterals which are not focused on communicable, right? So you've obviously USAIDs and Stop TBs, but you've also been part of World Bank and other places, right, where you've sort of possibly had a bit more focus on non-communicable. So tell me a bit more about both the things, maybe Samrit for lung cancer first, and then how do you sort of see this international experience and how do you think that India could learn from some of those things?
Sure. So when it comes to Samrid, it started as a initiative focused on COVID and as a COVID response, how we can kind of help entrepreneurs scale up their operations. We're working in the COVID space, but the long-term sustainability plan that we are working right now on looks at Samrid becoming a multifaceted facility, not just focused on COVID, but other health related areas as well. Could be NCDs, could be maternal and child health, could be lung cancer. So it should not be restrictive in nature going forward. So that's the plan in the next coming 1 to 2 years to transform it into a wider facility, looking overall at health system strengthening. And right now also slowly we are moving towards initiatives which are wider than just COVID response and are strengthening the health infrastructure in the country widely. When it comes to international experience, I think India in many ways has been much ahead of other developing nations, and specifically when we speak about countries in Africa, when it comes to both public health as well as private healthcare responses. We work very closely through the PEHEL program now in the East Africa region as well, where we are trying to take some of the initiatives supported through PEHEL and the Samrid initiative to other African countries. And we have seen that there's a lot of reception to them. And what is possibly required is like for initiatives like Qure.ai and all, to look at African markets much more closely, because what you will find is that the requirements there are very similar to that of India, but probably 10-15 years behind in terms of public and private healthcare response. And in that kind of a scenario, we can definitely, especially the technology-based solutions emerging from India, can definitely help other developing countries leapfrog 1 or 2 decades when it comes to the health improvements in those countries. So I would suggest, and we have been kind of encouraging a lot of our partners to look at African countries as a market for expansion of their business, besides India, of course.
Understood. I think, yeah, that makes a lot of sense. I think and that's true for Qure also, honestly. I think the work that we have done with Dr. Tipre in India, with Madhav, with across, all the sites in so many parts of India, I think we have seen that replication of that effort in a lot of other places as well. So we have a lot of presence in Philippines, Vietnam, Malaysia's, and then obviously a lot of places in South Africa and other African countries. So I completely understand where you're coming from and what you said, right? That's actually something we have seen so true and so close at home. But possibly, I think the question that I have now is for Naresh in terms of Naresh, obviously, it's very difficult for you to now, ask something like manufacture a new drug for some other disease areas. I don't think I can ask you for that. But in terms of obviously the go-to market, as you said, your role, I think, where you are seeing is sort of, trying to take some of these innovative solutions that Madhav or Himanshu is sort of putting up, and how can you take that to a bigger scale, right? So in terms of that, are you sort of trying to look at, obviously the QXR is something that we have been working upon and we see there's a potential, but other than that, do you also think to sort of look at universal lung health or possibly even healthcare, because you're not just only focused on lung health, you have hepatitis, tackled that earlier. Do you think that's something that you might be, how do you look at that sort of taking solutions, not only just, QXR or lung health solutions, but possibly solutions across it? But before Naresh, I allow you to answer, I just wanted to mention for all our audience, we have opened up a poll, which you can see on your screen right now, which is, we want to understand what you think are the benefits of integrated lung health screening. We'll also ask our panelists, but at the meantime, why don't you give up your answers and your poll in terms of what you think is the benefit, and we'll come back to panelists in terms of understanding their opinions. But yeah, back to you, Naresh.
Interesting. I think, as I said, we want to be really a go-to-market people here. Basically, if you see our organization, when we create an offshoot of Pfizer, which is Upjohn and Mylan, when they merged together, they created Viatris. So the core goal of creating Viatris is we have created a global healthcare gateway where we want to take up different solutions to the market. So that is the core goal we are driving. As I said in my earlier discussion, we would like to be into the space of end-to-end disease management. And I think lung health, this is one space which we have taken. And I think we are working very seriously in this space. And as you have seen in HIV, our work in HIV, our work in viral hepatitis in India, as well as now this space. So my suggestion will be like, we should have a quick decision when we are maybe when we are working with government. I think the decision making has to be little quick, and all of you are, I think, the right people to work with government, where we can have the policies. I think the policy drafting and working on policies should be a very quick space. I think government has already taken a right step in creating a good infrastructure for all these digital initiatives. I think NDHM base has been already set up. I think very soon we will see that the infrastructure for digital solutions or the disease management will become the reality in India, which is what we are looking forward. Over to you, Rohit.
Naresh, I have just one more question for you. I mean, it's very interesting because I thought this is something that I really wanted to ask you. So drug delivery and the supply chain logistics about it is one of the most interesting and complex problems in healthcare, right? A lot of people have tried to solve it at different places, and specifically being able to deliver drug at the doorstep of the patient, right, is a very interesting problem statement to solve for. And I think to your credit, I think Viatris and Mylan previously, right, has been able to solve that to a good extent. Just want to understand, do you see that infrastructure is something that we can possibly leverage on for other disease areas, right? I mean, is that supply mechanism, supply demand, logistics is as strong and mature to sort of support other disease areas?
Yeah, I think rightly said, COVID was one fantastic example where we all saw that. I think that physical touch where we used to feel, if for an imparting knowledge, you have to meet a doctor. I think that is looking like a past now, because there is a good digital as well as physical combination has started in that space. As well as when you see the other side where the awareness to the patient, I think there are a lot of digital initiatives are helping patients. Now, I will say that sometimes patient read more about the disease than the doctor. Sometimes we get into that kind of situations. Answering to your question, supply chain, I think COVID was one good example where we worked on both the most important drugs during COVID. One was for fungal infection and other was remdesivir. We created a digital supply chain mechanism under as per the guidelines of DCGI, where there should not be a misuse of the drug. I think the digital mechanism, I will say that was one of the very starting point. But what you said is India needs now a big, maybe a disruption in this space. I will say that where you can track medicine starting from maybe raw materials starting from manufacturing till formulation, and then how it moves across the journey and it reaches to the end user. Of course, this is one space which is I keep suggesting to a few friends in the startup area. I think this is one space we should evolve. Yeah.
Thanks a lot for mentioning that, Naresh. I hope we possibly could also play a role in that. Thanks for mentioning that problem statement. Maybe my colleagues at Cure are possibly also listening, and we could possibly look at that. But I think we are close to almost the end of the session. I really have a lot of questions for everyone else here. I just don't think I have enough time to do that. But I just want to take a few questions. I think one that has been asked on the channel, and any of the panelists whoever thinks it's, you please feel free to jump in and answer the question. I'll read out the question for you. It's from Krish Dasgupta. He's saying that great session, panel and Rohit. According to the latest post by Hopkins Medicine, post-COVID recovery, many patients have been diagnosed with further lung infections, be it acute respiratory distress syndrome, sepsis, superinfection, or bronchitis. It has been a matter of concern, fairly so. Is it possible to create a prognosis and recovery map? Just a minute, yeah. Prognosis and recovery map for each patient post-COVID recovery. How would that fit in the cycle of universal lung health. I think all of you can also see the question on the Q&A panel, but anyone wants to jump in specifically, I would request someone like Dr. Tipre or Professor Dr. Behra, because you have been on the front line, you've been treating patients, so you know about COVID recovery and how that has sort of been affecting.
So I would like to just mention that the chest physicians during the meeting do have mentioned that post-COVID we have seen extensive tuberculosis, maybe because they have delayed their diagnosis, fearing a quarantine and COVID testing, so neglected the symptoms. But also what we are seeing is post-COVID, after a few days, say maybe 6 months or 7 months, we are seeing a reactivation of tuberculosis. So we have started analyzing the data, and we have asking now one question in the past whether you had COVID to the newly diagnosed patients. So maybe in a few months down the line, we will have data to say post-COVID there is an activation or increase in the TB cases.
Understood. One quick question, I think, before I think the last poll is opened up, which you can see on the screen, which is what is one thing that will make lung health a reality for everyone. You can see the options and jump in, but meanwhile, while you do the voting, I'll sort of come back to some of the questions on the chat. One is all confirmed TB or COVID-19 cases should be assigned an outcome. Could you comment about outcome definition in these diseases, right? I see this is a question from Traian Mihascu. I think I pronounced your name correctly. Sorry if I did not. But anyone wants to take a shot at that? It says that all confirmed TB or COVID-19 patients should be assigned an outcome. Yeah.
So Rohit, I kind of tried to answer that in the chat window earlier. So
okay.
Say COVID and TB both have a very clear outcome. The patient should get cured. And then there are certain other things that should be accompanied. So I mentioned the Mukti program that we have been doing in MP. The outcome we measure is that there is a treatment success is there, as well as the patient gains 6 kg or more weight, so that the success is continued and the patient can live a healthy life post that treatment. So, and similar outcomes on the COVID side is of course cure from COVID, as well as ensuring that there are no other impacts on any other of the vital organs, and those are also taken care of in the follow-on treatment if required. So these are some of the outcomes, and these are very, very clear specific diseases where the outcomes are easily definable and should be monitored at different levels.
Perfect. Thanks, Himanshu. I think we are close to the end of it. I don't want to bother and sort of, with more questions. I think the poll is out there. So while everyone's answering, I think I just possibly ask the poll to the panelists, right, before we reveal the answers. So the question is, what is that one thing that will make lung health a reality, right? If you have to just take one choice, the 3 options are increased patient awareness, lowering diagnostic and treatment costs, and increased screening using technology. Those are the 3, and there's an option called others, but we'll sort of keep it to 3 options. Maybe we start with Madhav. What do you think is that one thing that, if you had to choose among those 3, what is that one thing that would possibly make it a reality?
It's definitely the use of technology to increase screening.
I would have thought so. Coming from you, it wouldn't have been any other answer. Fair. Himanshu, over to you. What do you think
I
is
think
that?
So increased use of technology is definitely going to lower the diagnostic and treatment costs. And with that, if you have some kind of awareness campaign, that is all we require.
Okay. Naresh, what do you think?
I think, of course, screening more and more people by using technologies, my goal.
Dr. Tipre, what is your pick in terms of the 3 options?
I'm the panelist, but at the same time, good awareness in the community also plays a very big role. Otherwise people, they don't come forward for testing.
That's actually very interesting. But although as a AI company, we would like to think that screening using technology possibly is an answer, but that's so true. I mean, if you don't get people to be aware that there could be so many other things being done, it's very difficult to make that a reality. And I don't know, Dr. Behra, if you are still there with us, maybe possibly would like to get your thoughts on this one. Else we'll possibly, we can disclose the results. I don't know, Qure team, if you can possibly show the results, what the rest of the teams thinks that might be very interesting. There you have the results. I think, yeah, good, whopping 54% of the people think increased screening. I just hope that's not the Cure team that's out there in the audience and voting. But just genuinely grateful to everyone on the panel today for taking out your time and participating and sharing so much insights and valuable understanding of the work that you have been doing, and also how you think universal lung health could be a reality. Genuinely grateful to you for all the support to Cure and also to the panel discussion today. Thanks a lot, and let's keep in touch.
Thank you, Rohit. Thank you, everybody.
Thank you.